Good afternoon, everyone. I call this meeting to order. Bonjour et bienvenue tout le monde. Welcome to meeting number 7 of the House of Commons Standing Committee on National Defence. Today's meeting is taking place in the hybrid format pursuant to the House Order of September 23rd, 2020. Proceedings will be made available via the House of Commons website. So as you are aware, the webcast will always show the person speaking rather than the entirety of the committee. So today, just to bring to your attention, we have a total of 6 witnesses on the docket for today. So I will be particularly strict when it comes to the time issues and your allocation of time for questions, just so that you are pre-warned. So I think it's really important that we get all of these witnesses have something to contribute to our study, and I want to say thank you to them for joining us today. I'll welcome our visitors, a short little bio. So we have Carol Estabrooks, adjunct professor at the School of Public Health at the University of Alberta. She was chair of the Royal Society of Canada's Working Group on Long-Term Care, whose members include other esteemed members we have heard from. Working group issued a policy briefing in June of 2020 that outlined the deficiencies in our long-term care sector and recommendations for action.
I'm very sorry to have to start this wonderful committee. I know we don't have a lot of time, but I have to raise a point of order. I'm not receiving the translation in French. I have chosen French interpretation. Am I the only one having this problem?
Merci beaucoup.
Thank you for pointing this out. Can you speak, please? Well, I can speak, but then I'll be speaking French.
Oui, maintenant je vous entends. Oui, c'est parfait. Merci.
Okay, I hear you now. Thank you. Thank you very much.
Merci beaucoup, Monsieur Brunet.
Thank you, Mr. Brunel.
So we'll continue. Régent Hébert is a professor in the School of Public Health at the University of Montreal, and he was a member of the Chief Science Advisors Task Force on Long-Term Care, and again, talking about recommendations, how we address the challenges of combating COVID-19 in long-term care homes. Then we have Mr. Richard Shamuka. I hope that's pronounced correctly. He is the senior fellow. He's with the Macdonald-Laurier Institute, and he writes extensively on the Canadian Armed Forces. We have Madame Michelle Van Beuzekom, who is a co-founder of Protect People in Long-Term Care. It's an ad hoc citizens group formed in April of 2020 to encourage decisive action to address COVID-19 in long-term care facilities. And then we have 2 officials from the Department of National Defence, namely Colonel Scott Malcolm, Deputy Surgeon General, and Major Carolyn Martin. She was the commanding officer for the Canadian Armed Forces personnel deployed into long-term care homes. Considering the number of witnesses before us today, I have asked them to try and limit their introductory notes to 5 minutes. But considering that some had already prepared 10-minute speaking notes or background documents, I would like to seek the members' agreement that the longer documents, once translated, will be provided by the witnesses to be annexed to the evidences of this meeting. So any comment on? All right. Thank you, everyone. I appreciate that very much. So with the administrative part of this complete, then we will begin with the opening remarks from Professor Estabrooks, please.
Thank you very much. In Canada, we are fortunate that we have the capacity to call upon the Canadian Forces in crisis. I'm thankful that they stepped up to provide care in nursing homes during the first wave of the pandemic, going into unfamiliar and besieged care settings with little time to prepare. I'm grateful that they stabilized parts of the long-term care system that had moved into deep crisis, preventing further suffering and unnecessary death. I am grateful that they fulfilled their duty to report and that those stark reports riveted the attention of Canadians and our leaders on the unfolding catastrophe. In Canada, over 80% of total COVID deaths have been in long-term care, far outpacing any other country in the world. How could this happen? Only by valuing older adults, and in particular, older adults with dementia less. Only by valuing nursing home care less than the care in hospitals and ICUs. We knew early in the pandemic that things in care homes were not good and could quickly become catastrophically worse. That attention and action favored the young and the hospitals. That decades of inattention, of managing on the thinnest of razor edges, had created these conditions. Still, when the military reports of COVID conditions in nursing homes came out, we gasped, we wept, and for some, a smoldering rage began. I regret that our men and women of the armed services had to step in, but I'm glad that they did. Our governments and our society at large have known or should have known what has been happening. For example, the Royal Society of Canada report on COVID-19 and the future of long-term care identified over 150 media reports in just the last 10 years about the state of nursing homes in this country. For over 50 years, reports of abuse, insufficient resources, neglect, and so on in long-term care have been produced by governments, organizations, unions, and the media. In the last 3 decades alone, over 80 Canadian reports have been produced and at considerable cost, and common themes have emerged, but little has been done. Every event was seen as an independent and siloed occurrence, and not part of systemic and long-standing problems. At the heart of the long-term care and workforce challenges, in addition to ageism, is also undisguised sexism. Caring for the elderly in long-term care is considered just women's work that anybody can do. This is, of course, patently false. This is complex, demanding, and skilled work. It is delivered by personal support workers, over 90% older women, over 50% immigrants, paid the poorest of any worker in the health system, often without benefits or the security of a full-time position, with poor preparation and little to no ongoing education. Our modern-day workforce of the 17th century Elizabethan poorhouse. Before I end, I want to speak briefly to mental health among the military and civilian workers under COVID conditions. We know that they are and will continue to face mental health challenges. In Italy, early estimates of moderate to severe anxiety and PTSD among long-term care workers approaches 50%. Mild symptoms approach 90%. These effects will linger for years and decades, but they will be less devastating if we act now to support the frontline workers and the older adults in care homes who have survived. I am pleased to see support for the mental health and well-being of military personnel who were on a temporary assignment. We must turn now to the mental health and well-being of long-term care staff on permanent assignment who have no such support. In conclusion, I want to thank the Standing Committee for inviting me. The long-term care system into which we place our cherished loved ones has endured long-standing neglect because of undisguised discrimination toward the old and toward women who do the honorable work of caregiving. COVID-19 conditions in nursing homes have brought forth the deepest existential fear of many Canadians, the fear of dying alone. Just as Passchendaele has come to symbolize the senseless slaughter and unimaginable suffering of Canadians who serve, COVID-19 in nursing homes has come to symbolize unnecessary death and senseless suffering among those who built Canadian society, who worked to make this one of the most desirable countries in the world in which to live. We do not need more commissions or inquiries or reports. What we need is a modern-day equivalent of a bold Marshall Plan and its resources to accomplish a root and branch overhaul of the long-term care system. If we do nothing, then once the vaccines are administered, once COVID-19 has passed, once memories fade, once new priorities take center stage, nursing homes will return to pre-COVID conditions until the next virus. It doesn't have to be this way. Our oldest citizens can live serenely, enjoying the last stage of life in nursing homes, where their carers have time to contribute to the quality of their lives, as well as providing high-quality care. We can choose which it will be. Thank you.
Thank you very much, Professor Esther Brooks. Professor Hébert, s'il vous plaît.
Vous êtes en sourdine.
You are still on mute, Mr. Hébert. Thank you very much. And good morning, everybody. First of all, I'd like to thank the Standing Defense Committee for this invitation. This is probably the only time in my career that I'll be invited to the National Defense Committee. It's rather far from my usual concerns. I would like to support what my colleague Carl Esterbrook has just said. Excuse me, Mr. Hebert. Could you hold your microphone closer to your mouth, please, so that the interpreters can hear you? So I would like to support what Ms. Esterbrook has just said. I am in full agreement with her analysis. We don't have so much time to speak to you, so what I would like to do is emphasize various facts which should scandalize the population of Canada. During the first wave of COVID, Quebec had what I would call an ageicide, murder of the aged. This is really the word that I'm choosing, ageicide. 10% of people living in long-term care institutions in Quebec died in the first wave of COVID. 10%. In Ontario, 2.3%. In BC, 0.6%. In all other European countries, only Spain came anywhere close to us with 5.3% of institutionalized long-term care patients dying during COVID. We had twice as many deaths. Why did Quebec have this massacre? There are several reasons for this. I'll list a few of them. So that what happened in Quebec should never happen again in Quebec or anywhere else. In Quebec, we saw the illustration of the fact that long-term care centers and institutional living has been neglected for the last 3 decades. First of all, management and governance of long-term care institutions has been swallowed up by much bigger healthcare institutions. Beginning in 2003, boards of directors and branches of the long-term care centers were abolished, and they were merged into those of hospitals and CLSCs, the local community health centers. That was the first reform, which caused a loss of administrative independence for the long-term care institutions. Then in 2015, there was a new structure where we had the integrated centers of health and social services. Rehab centers, youth centers were also integrated. And entire regions' facilities were merged together. So in Quebec, we have huge ensembles with several different missions, including hospital mission, of course, as well as frontline service mission, long-term care services, youth services, and rehab services. New Brunswick and Alberta also experienced this kind of merging of establishments and institutions, which are hospital-centric and which marginalize the other missions of these large ensembles. So we end up with long-term care centers who can no longer self-manage. And it's Yves Benoit, the investigator who wrote an investigation report on what had happened in the long-term care center at Saint-Dorothée. There are 5 hierarchy levels between the local management in a long-term care center and the actual management. 5 different reporting levels. And if you add the government department, that's a 6th level in the hierarchy. So in order for a problem to be brought forward and to get a response, it can take several days or weeks. And so this leads to terrible loss of agility. There's a second major issue, and that's understaffing, especially in personal support workers, because this type of work has been devalued in recent years, not only in terms of the kind of compensation offered, because the pay was not sufficient, but also, and above all, the work has been dehumanized. Every minute is counted and attributed for particular activities. In other words, we have forgotten that the role of a personal support worker is to provide emotional support to residents, and that's what makes them feel good. There has been a drop in the quality of the workplace in the last 5 years as a result of this major reform of 2015. This deterioration is translated into over $500,000 extra dollars in health insurance and had salary insurance and overtime and use of independent labor. Third big problem, the nursing staff has been deteriorated. Doctors have been encouraged to go to their private offices, and so the nurses have been left alone, and even the nurses have been sent to the hospitals. So there is not a lot of medical or nursing staff in the long-term care centers, and they cannot properly care for patients and take care of them when there's any serious or acute deterioration. Third and fourth major reasons. The facilities are obsolete. We have facilities where there are multiple beds in a room, people are sharing bathrooms, there's poor ventilation, no air conditioning. Institutions where they don't have any extra rooms if anyone is in an end-of-life situation or infectious and contagious. There's no isolation capacity. The pandemic management was lacking because the pandemic was not managed by preparing hospitals and transferring people who were transferred in massive leave out of hospitals to long-term care centers. Hospitals were given priority for prevention and control of infection. And so what we ended up with was negligence in the long-term care when it came to prevention and control of infection. We had staff mobility. It is still happening now. And that led to outbreaks and transmission of the virus. There were problems of lack of PPE. Again, priority was given to hospitals. Personal caregivers were not allowed to come in. And so not only did they provide personal support and emotional support, but they were also providing daily care. We had a very late designation of hot zones during the outbreak. And there were not enough testing kits available for staff who were working in these institutions and facilities. All of this negligence led to a major crisis. Imagine 10% of the children in schools, 10% of children in daycare, 10% of members of any indigenous community. It would be scandalous. Everybody would be furious. But no major old age or old life matters. Old lives matter. And I agree with what Mrs. Esterbrook said. There is ageism here, and it's barely veiled, and this has been revealed by the pandemic. I would like to thank the Canadian Armed Forces for having come to help us to limit the damage. Thank you very much, Madam Chair. Thank you very much, Professor Hébert.
Et maintenant, Monsieur Richard Shimoka, s'il vous plaît. Merci de m'accueillir à cette réunion de comité. Mon rapport d'aujourd'hui est fondé sur interpreter's mistake. I'm sorry.
Traduction française. Il n'y a pas de problème, merci. C'est réglé.
All right, the problem has been resolved. Thank you.
Okay, good. Thank you. I'm a senior fellow at the MacDonald Institute, where my focus is on international security and the strategic and military studies. In the past year, the COVID-19 pandemic has caused significant dislocations to Canadian economy, politics, and society. However, as we look into the international sphere, the pandemic has accelerated a number of longstanding trends and introduced several new challenges. Over the past decade, we have witnessed the fragmentation of political, economic, and military arrangements that underpin a rules-based international order. The post-Cold War consensus has broken down and driven in part by a growing absurdness of national actors in international relations. Russia, China, and Iran have rejected or worked to usurp this Western-led order. The fraying of the post-Cold War consensus has occurred among our close allies, where populism, nationalism, the fraying of the post-Cold War consensus has occurred also among our close allies, where populism, nationalism has emerged as powerful and a disruptive force. Their growth is variously blamed on historical lows in public trust of governing institutions, declining economic prospects, and rapidly changing societies. Manifestations include populist leaders such as Viktor Orban in Hungary or Jair Bolsonaro in Brazil. One of the clearest indications of this emerging era of global power competition is evident in the military sphere. Over the past decade, a dramatic modernization effort has been undertaken by major military powers, encompassing increases in funding, reorientations of force structures, and the fielding of new capabilities. The breadth of these technological advantages arguably sets the period apart from earlier eras, which will affect the fundamental nature of warfare, like with artificial intelligence.
Point d'ordre, Madame la Présidente. Je suis désolé. L'interprète fait ce qu'elle peut. Malheureusement, c'est trop difficile d'interpréter le témoin. Peut-être, par contre, s'il parlait plus lentement, ça pourrait aider notre interprète parce que
The interpreter is doing her best, but the sound quality is not sufficient to support interpretation.
If we could please have the interpreter do their work because they're having a very chopped up sound, and maybe if the speaker could slow down.
Could put your microphone, speak more directly into it and a little bit slower. It might help. We'll do a little test, 5 seconds.
That better? Is that okay? Thank you.
You need to test a little longer, 5 seconds, so we can just fix that, please.
Oh, is this fine? Are we good? Are we okay here? Okay, thank you. Collectively, these new technologies have increased the lethality and potential ways to apply force. Many are vast improvements over existing systems or of no preceding analog. The technological developments are not strictly limited to military kinetic issues. They also affect our political, economic, and social systems, such as with cyber capabilities. Perhaps one of the most problematic aspects of this emerging military reality is the lack of norms around these new technologies, which may result in greater instability.
Well, Mr. Schmucke, can I ask you just to speak a little louder?
Sure.
The microphone isn't picking it up very well, and
Sure.
it's hard for our translators. Thank you.
Not a problem. The COVID-19 pandemic has further undermined public trust in governance structures of Western states, a fact that is exacerbated by the disinformation campaigns conducted by foreign powers. This is evident with major protests and civil unrest surrounding public health measures and the rise of violent far-right militias in several countries. Moreover, states' emergency economic response to the pandemic has saddled many with large debt loads, which will require decades of austerity measures to eliminate, thereby limiting their ability to address domestic and foreign challenges. The challenges are particularly key for developing states, which are less well equipped to handle economic and political consequences of the pandemic. They face a weakened global trade system, a growing risk of political fragmentation due to the same forces that are affecting developed states. Thus, in its aftermath, many states will adopt strong domestic focuses to rehabilitate their economies and societies. This is evident in Canada's southern neighbor, where the incoming Biden administration has already highlighted their immediate need to focus on domestic issues upon entering office. In foreign affairs, the president-elect was clear. He believes that diplomacy is the primary foreign policy tool of the United States and intends to work through alliances and international institutions. While his administration will likely provide greater leadership than its predecessor, this means that Canada and other allies will need to shoulder an increasing burden for international security, despite facing the same economic and political challenges as the United States. At the same time, we will be less able to rely on multilateral institutions, which has suffered significant legitimacy and credibility issues as a result of the pandemic. The Canadian Armed Forces are likely to experience greater foreign demands in the coming years, as weak states succumb to centrifugal pressures created by the difficult economic and political environment, with fewer developed states willing to assist in stabilization efforts. The nature of these conflicts also pose significant risks for the Canadian Armed Forces. The proliferation of new technologies and capabilities will greatly complicate Canada's ability to intervene as well. The conflict in Nagorno-Karabakh shows how relatively modest unmanned aerial vehicles can have decisive consequences on the battlefield. Particularly concerning are their low costs. Armenia and Azerbaijan are relatively modest economies that could easily afford these novel capabilities. Moreover, it is not just the low-end conflicts that the Canadian Armed Forces must prepare for. We can observe that China has thus far weathered the pandemic in better condition than most other developed economies, posting a positive growth rate for the rest of this year. Meanwhile, the Russian Federation has continued to play a spoiler role internationally despite suffering the pandemic's effects. Thus, the challenges of great power conflict will likely become increasingly acute as the decade wears on. To respond to these challenges, the Canadian Armed Forces must become increasingly nimble as a response to them, nowhere more so than how it acquires and incorporates these new technologies. The 2017 Defense Policy White Paper, Strong, Secure, and Engaged, is far too rigid in this age of rapid technological development. Many of these systems require quick, iterative upgrades to maintain the fighting edge, which our government is not well organized to deliver. The procurement system itself is severely hampered by an overly regulated oversight system, which ensures project delays and cost overruns. These issues exacerbated by the reality that successive governments have seen defense procurement as a vehicle to direct government money into domestic constituencies. This only causes further delays to procurements and eats into the defense budget. The temptation is to further exploit defense procurements to these ends will be particularly acute given the severe economic challenges facing the country. None of this suggests that Canada should act like a global policeman at the outbreak of violence. However, the trajectory of recent international relations, particularly after the pandemic, suggests that the world is becoming increasingly unstable and that military force may be required to ensure this country's security and prosperity. Canadians must be clear-eyed to these challenges that they face, and the country must possess the appropriate tools to address them. Thank you.
Thank you very much, Mr. Schmucke. And now, Madame Van Boisekamp, please.
Hello. Thank you, Madam Chair and committee members, for the invitation to speak here today. I'm a co-founder of Protect People in Long-Term Care, an ad hoc citizens group that on April 7th launched a petition asking for emergency funding for LTCs, a national coordinated strategy, and the implementation of shared standards. To date, our petition has garnered over 98,000 signatures from every province and territory in Canada. I'm also speaking to you today as someone with a unique lived experience and perspective. Both of my parents live in Grace Manor, one of the 5 LTCs in Ontario that received military assistance in May. I'd like to underscore that many of us with loved ones in LTC saw this tragedy coming. We are intimately familiar with the systemic gaps and failures in this sector. And when we saw what was unfolding in Spain and Italy in February, we quickly realized what was coming our way. Chronic understaffing is endemic in this sector. And when families and volunteers were locked out on March 13th in many parts of the country, we knew that staff who are already overstretched would quickly become overwhelmed. Our anxiety rose as we learned that LTC staff were having to fight to get access to PPE. And we watched in horror as outbreak after outbreak was announced. Yet LTCs in many jurisdictions were not being prioritized by their public health authorities for access to testing to ensure the rapid assessment and cohorting of residents. My parents' LTC in Brampton, Ontario, reported their first case of COVID on April 7th. Each day the numbers rose, but they had to wait an agonizing 8 days after that first positive case until their public health authority, which was following Ontario Ministry of Health directives, would finally give them access to testing for all residents. And by then it was far too late. In their LTC, with a population of 120 residents and 36 staff, there were 65 resident cases, including both of my parents, and 21 staff cases, which ultimately resulted in 12 deaths, including 2 staff. With staff levels so depleted, those remaining were working up to 16 hours a day. The senior administration at Holland Christian Homes, the not-for-profit which runs Grace Manor, reached out to the province of Ontario and the local health authority for help. They hoped to partner with the 2 local hospitals in Brampton and to receive redeployed medical staff from those hospitals. When that didn't happen, they asked, as a last resort in an increasingly desperate situation, to be considered for military assistance. On April 24th, the Ontario government formally made the request for military assistance on behalf of 5 homes. For Grace Manor, that assistance was vital. Half of their staff was gone. The military presence gave remaining core staff the breathing room to recruit, bring in, and train new staff and ensure proper infection control protocols were firmly in place. Military personnel also provided much needed human contact for residents, many of them frail, vulnerable, and confused, who by this point had been completely cut off from any in-person visits with their families for over a month. My father so appreciated his conversations with the military personnel from places like Nova Scotia and Petawawa. It was a good thing they came, he told me yesterday. But why did this happen in the first place? Why was military assistance needed? How did it get so bad? As we've heard today, it got this way after decades of political leaders ignoring dozens of reports that flagged a host of critical systemic issues: underfunding, chronic understaffing, poor labor practices, the lack of shared standards of care and training standards, deregulation, privatization, and absence of accountability. We had plenty of warning. The catastrophic failure of our most vulnerable should not have happened. And here we are today in a second wave. Over 12,000 people in Canada have lost their lives to COVID. 80% of all deaths in the first wave were of people living in long-term care, the worst record in all OECD countries. Dozens of long-term care facilities across Canada are once again in outbreak, and yet the same struggles with access to testing and rapid cohorting that we saw in the spring continue. Kat Cizik, one of my co-founders, her dad lives in Lakeside in Toronto, an LTC currently in outbreak where COVID-positive residents have been left on the same floor as those who have not contracted the virus. Another co-founder, Kitra Kahana, we're only 4. She is seeing staff and resident infections skyrocket at the Maimonides facility in Montreal where her father lives. Despite this alarming outbreak, the Public Health Authority has not made testing mandatory for staff and visitors. I don't have words to describe how excruciating it is to watch this again. Despite all we know, all we learned in the first wave, all the studies, the policy recommendations, so little has been done to address the root problems that have caused this crisis. We should not be relying on the military for last resort crisis management in a sector where the problems and the solutions are this well known. This is not a good use of military resources and training, and I'm sure it has compromised military operations and budgets in many ways to come to the aid of a sector where private operators have continued to reap handsome profits for their shareholders throughout this crisis. We've begun to see reports of how Operation Laser has impacted the mental health of military personnel who are thrown into an acute crisis situation in a unique environment that they didn't necessarily understand. Military medical staff are not long-term care specialists. Caring for high-needs elderly, over 80% of whom suffer some form of dementia, is a skilled activity, even if our society does not recognize it as such. In the throne speech on September 23rd, the federal government made a commitment to national standards. Yet almost 10 weeks later, details and a timeline have not been shared. It is so disheartening to see the jurisdictional bickering that is blocking the groundswell of grassroots support right across this country for national standards. And it is imperative that all levels of government come together to fix this broken system. I am so thankful that the military were there for my parents and for Grace Manor, and I never want to see this happen again. This sector needs to be properly supported. The long-standing problems need to be addressed. We need concrete action on those national standards, and the military has other work they should be doing. Speaking on behalf of the 98,000 who signed our petition, I hope we can count on you to help make that happen. Thank you.
Thank you very much, Madame Boisacom. And Colonel Malcolm, I believe you are presenting the opening statement.
Yes, Madam Chair, thank you. Madam Chair and members of the Standing Committee on National Defense, it is a great honor and privilege to be here today along with Major Carolyn Martin, and I thank you for the invitation to discuss elements of the Canadian Forces Health Services deployment into Ontario's long-term care facilities, supporting Canada's most vulnerable in the midst of the COVID-19 crisis. As you have heard in previous testimony, Operation Laser saw the deployment of hundreds of health services personnel, nurses, medical technicians, medical assistants, physician assistants, and dental personnel all came together to form composite teams known as Augmented Civilian Care Teams. As the Director of Health Services Operations, I was the architect behind the medical aspects of the plan that saw the Augmented Civilian Care Teams deploy into long-term care facilities in Ontario. Major Martin had the distinct pleasure to deploy as the officer commanding the Augmented Civilian Care Teams within Ontario. From April to August, we deployed into 7 long-term care facilities with the primary mission and goal of saving Canadian lives. Upon our arrival, we witnessed the sector in crisis. Our clinicians and Canadian Armed Forces personnel immediately mobilized and began to work tirelessly alongside our civilian health partners to stabilize the situation and support not only residents, but the organizations and clinicians we were deployed to support. Although CAF personnel are not experts within the long-term care sector, we responded to the call during a critical moment in Canadian history. Clinical excellence, compassion, and patient advocacy are the cornerstone ethical principles of all Canadian Armed Forces clinicians, which they live by. And as such, when concerns regarding the conditions and the standards of practice arose, we as Canadians, clinicians, and as soldiers had a clear duty to report our observations. I would like to stress that our observations were only a snapshot in time that reflected the realities within the long-term care facilities in which we worked during the early stages of the COVID-19 crisis. The CAF Health Services personnel who deployed on Operation Laser are a passionate and dedicated group of clinicians who will always advocate for patient and resident well-being and the provision of high-quality health care to Canadians. It is with this lens of systemic improvement that we graciously accept your questions and queries. We thank you once again for this opportunity and look forward to your questions. Thank you, Madam Chair.
Thank you, Colonel Malcolm, and thank you to all the witnesses for keeping your remarks brief, and that leaves more time for questions. So we'll start the questioning round. Firstly, Mr. Benson, s'il vous plaît.
Thank you, Chair, and thank you to all the witnesses for appearing today.
Thank you.
It's greatly appreciated. Mr. Shamuka, you mentioned in your opening remarks there that we have a new global era of competition being marked by increased modernization of the military and lots of new technical advances. Can you give us some sense of what other militaries are doing in terms of this modernization and advances, and tell us then if the Canadian military is keeping pace with that, and also how the COVID-19 may be affecting our ability to do that.
Sure. So I think if we look at, as I stated in my remarks, the nature of the technological development is quite broad. It's not just one or two areas like in previous eras. Like it's not just, let's say, ICBMs, or it's intercontinental ballistic missiles, or it's not just greater communications. It is basically in almost every area of military conflict or military capability, we're seeing some advancement. And that's part driven by something that's generally called these sort of broader technologies such as AI, which is affecting how all capabilities are starting to operate together, greater connectivity between different military capabilities. So you see much greater focus on networked capabilities, as well as some very sort of specific and unique capabilities that are narrow in focus, such as hypersonics, which is a significant area of growth in the last decade or so between the United States, China, Russia as well. Russia's recently just deployed several new types of hypersonic weapons on large large missiles or carried by airplanes. So in that sense, there's quite a few areas that Canada has to the Canadian Armed Forces must be aware of. And as I said in my remarks, if we look at Azerbaijan and Armenia's conflict just recently, UCAVs were a significant part of that conflict, and it really did change what occurred and the outcome. And those capabilities range from very low cost, items that cost several $100s, to extremely expensive, unique capabilities that have very wide effects. The Canadian forces are trying to adapt to this capability. I would argue that in many cases they have not received the priorities that were laid out, let's say in 2017, may not be as relevant as they are today. One of the best examples, referring back to Nagorno-Karabakh, is the development of new types of air defense systems. And I'll give you an example. In the United States, I believe there's now 6 or 7 ongoing air defense system projects that the U.S. Army is undertaking and implementing into service. Canada has one program, the Defense Capability Guide. It is the GBAD's program, and it is identified for delivery, I believe, in 2026 or 2027. That means that for the next 6 or 7 years, Canadian Armed Forces will not have a dedicated air defense system to defend against threats we just witnessed have decisive effects in a conflict that are easily and cheaply available to many different countries. So I think that kind of gives you a bit of a. Does that sort of answer your question? That sort of give you a perspective of where this is at?
I think you gave me some sense of what we need to do to modernize, and I think you're saying we sort of have to pick some niches. We can't do everything, but we have to pick some area. You mentioned something about waiting until 2026 to get this air defense, and you talk a lot about technological advances, the technological products we're buying now, but aren't delivered for 6 or 7 or 8 or 10 years, and yet by the time we get them, they're already out of date. In the COVID-19, we've learned that we have to be quick and nimble, and we have to do, we have to change on the fly. Is there something from COVID-19 that we can take as a lesson to shorten the procurement time to get our products quicker to us?
Absolutely, and I think that we look at how the development and the rollout of vaccines internationally. Like I'm utterly astounded as somebody who watches innovation and development of very high-end military capabilities, and we are literally watching in front of our eyes a modern scientific miracle, right? Where we've developed a vaccine from almost scratch in the space of a year and a half or a year, let's say, and had it basically rolled out and hopefully put into Canadians hands or arms or whatever,
right,
in the next in just over a year. And I think that's impressive. So I think one of the things that observing how government operates, especially during times of crisis, is that a lot of the rules, let's say, are a lot of the straitjackets that are placed on policy implementation are quickly removed in order to identify ways that we can be more efficient and faster to do what's required. And I believe that in terms of the military capability, there's been quite a bit of process been put into the system that has actually prevented the Canadian Armed Forces from getting the equipment that they need. I mean, if we're talking about GBAD specifically, I look at other countries that identify this problem, that UAVs that were that provide great threat to their countries, and they immediately purchase a system, put an interim system into operation, and then looked at the long-term solution, right? Whereas in Canada, I feel like in a lot of cases, we can look back to Afghanistan or other operations, we tend not to actually acquire the capabilities that we need until it's a crisis. And at that time, it's the worst time, right? And I would probably I'd probably ask some of the military members of this panel right now, like, if they did not have the capabilities that they need, and how quickly that they had to scramble to kind of get some of them, right?
Well, thank you very much.
That's the case. So thank you.
Yeah.
Thank you.
Did that go up? Mr. Baker, please.
Thank you very much, Chair. And I'd like to start by thanking all the witnesses for being here. We have so many wonderful witnesses, and I hope that we have the time to really have a conversation with each of you and hear from all of you. And rest assured, we'll all do our best to ask questions to all of you throughout today's meeting. First off, I'd like to say that in my community of Etobicoke Centre, we lost 42 residents to COVID-19 at the Eatonville Care Centre. And this is one of the homes in which the Canadian Armed Forces initially served in Ontario. And so on behalf of my community, I would like to thank Colonel Malcolm and Major Martin, I'd like to thank you and for your work, for your service, and for the service of the men and women who served under your command, for all the work that you did and for caring for and frankly saving the lives of constituents in my community. I'd also like to thank you for preparing the report about what you discovered, the horrific conditions you discovered in long-term care homes in Ontario and in Quebec. As a result of your report, certainly in Ontario, the 5 MPs who represented the homes in which you served ended up in late May writing to Mr. Trudeau, to Prime Minister Trudeau, and to the Premier forward and asking for a number of things, including national standards to be put in place for long-term care. And of course, as was mentioned by Ms. Van Bussicom, in the throne speech, the government announced that it would be working with the provinces to establish national standards for long-term care. Your report enabled awareness and transparency, which has led to advocacy, which has led to government committing to national standards. And when we get to those national standards and those are implemented, that'll make a difference for seniors for generations to come. So for that, I'm deeply thankful to you and all the men and women who served under your command. So thank you. My first few questions are for Ms. Van Bussicom. First of all, thank you for being here and for your testimony. What do you believe needs to be done to address the horrific conditions, frankly, and the practices that were identified by the Canadian Armed Forces in long-term care? And I'm really focusing on over the long term. I know that there's a response that's needed immediately in the context of COVID-19, and I'm not trying to deprioritize that, but I'm curious about what you think needs to be done over the long term.
Thank you very much for the question. And I think Carol Easterbrook has done a ton of work on this. I'm so thankful for all of the people who have been working on these issues for decades. The first one is staffing. As I said in my testimony, this sector has been chronically understaffed for decades. Family and volunteers were the glue that kind of held it together. And when they were forced to leave, it fell apart. And it, as I said also, it was not a surprise to us. In Ontario, the RN, the Registered Nurses Association of Ontario, and others have been advocating for 4-hour minimum of direct patient care per day. And that's a really good beginning. I mean, we need the staffing levels to be increased. We need proper funding for this sector. We need proper training for PSWs. I was talking to the doctor at Grace Manor yesterday, and he was saying, you know, why doesn't Sheridan College and others have programs that are PSWs for long-term care? It's specialized. As we've heard in today's testimony, it is a specialized skill to care for older adults with complex needs. We need standards of care, and it needs to be the same across the country. I mean, BC did great, you know. Early in April, they increased salaries for people who are chronically overpaid, which made it possible for them to work in just one home. They did really good in terms of the testing, but it's so even across the country. So we really need those national standards, but start with adequate funding and start with the staffing ratios. There are other things that can come in the medium and the longer term. But for now, we need to support those core staff, right? The military came in, and that was fantastic, but they don't have the relationships. The most important thing is the relationships with the residents, and that's what the core staff have. So we need to support those core staff who know the residents, who know what we need, so that they're not run off their feet. And this has been known for decades. We knew this before COVID, so there's no excuse that this isn't happening now.
I appreciate that very much. And I think I have about a little less than a minute and a half remaining in this segment. So Ms. Van Bussicom, I'll ask you this question, but ask you to answer within about a minute or so if you can. And the question is, first of all, I should say that MP Sonia Sidhu was the one who recommended that we reach out to you. And so thank you to you for coming today, but I wanted to let you know that. But Ms. Sidhu and a number of others, as I mentioned, advocated, and you have advocated tremendously, and others have, in our caucus and elsewhere outside of government, for national standards for long-term care. You alluded to that a moment ago. Can you just speak to why those standards need to be established?
Yeah, and I'm so thankful to Ms. Sidhu. When we launched our petition, we wrote to all kinds of federal and provincial ministers, and we got a lot of rote responses. And Member Sidhu was the one person that really engaged with me as a human, and I really appreciate that. The national standards are so important. I mean, long-term care should come under the Canada Health Act. The needs are complex. People are living a lot older. It's not just taking care of people, it's delivering complex medical needs. And Canadians should have that same guarantee that whether you live in Iqaluit, you live in Iqaluit, you live in Dawson City, Vancouver, Winnipeg, or Whitehorse, you get access to the same standards of care. That should be a principle of our country. And right now, as we've heard, it's broken, it's uneven, it's untenable, but we do know how to fix it thanks to the work of so many people.
All
Thank
right.
you very much.
Thank you very much for that. Monsieur Brunel-Duceppe, s'il vous plaît.
Merci, Madame la Présidente.
Thank you, Chair. I'd also like to thank all of the witnesses who are here today. I think we're talking about important issues, and I'd like to especially thank the two members of the Canadian Armed Forces who are here today. I'd like to thank you for all of the assistance you brought Quebec. So for my first question, it's for Mr. Hébert. First of all, hello, and thank you for being here today. I'm going to be quite direct. For decades, federal health transfers to Quebec have been decreasing. I imagine that you've worked as Minister of Health at the provincial level. So I'm wondering whether you could describe to us the impact of the accumulated lag or delay of the federal government in terms of healthcare administration in the provinces because of the reduction in health transfer payments, which were, I think, 50% initially at the beginning of the Health Act and now are 22%, 22 to 23%. Yes. Thank you very much, Mr. Brunel-Duceppe. Federal transfers have been reduced, but what's of more concern is the fairness of the transfers. Under the Conservative government, the equity was disturbed, so not only was there a leveling off at a certain percentage of GDP, but the distribution of the transfers depended on the population of the province without considering the age of the population, which clearly put older provinces such as Quebec and the Maritimes at a disadvantage. And this is an issue of fairness. And this caused a lot of difficulties to these provinces who had to deal with an aging population more so than the other provinces. What's very disturbing to me is the negligence in the way these funds were used by the provinces, in particular by Quebec. The money was used for hospital services and to compensate doctors, and institutional care was neglected, and the COVID crisis demonstrated this. But in addition, and especially, home care was neglected. Our Canadian system is based on the hospital. It was developed in the 1960s and 70s at a time where our population was young. And so it was based on the medically necessary care to be provided in a hospital. But with an aging population, the focus has to be more on long-term care, and the long-term care is much better provided in a home setting. And in Quebec and in Canada, home care has been neglected over the last 50 years. So when you look at the OECD countries, there's a 14% investment of public funding in long-term care, home care, and we're the last ones on the list in the OECD. Other countries, such as Denmark, invest 73% of the long-term care budgets in home care. If we had a better developed home care system, we would have been able to avoid some of the absolute massacre and bloodbath that we saw in the institutions, because several people would have stayed home had they had the choice, rather than moving into the institutional framework. I think that there's a major shift that has to happen in Quebec and in Canada. Just to clarify some of the things you mentioned, you will agree with me that healthcare costs with inflation have increased enormously in the healthcare setting. And on the other hand, federal transfers have dropped. I understand that choices were made in terms of how the funds were managed, but when the money goes from 20 to 22% and all the premiers of the provinces and territories are asking for 35%, do you feel that when there's access to these funds, if the federal government will transfer them as it should, it will be much easier for the provinces to do their job? My issue here is that even if there were more funding, it would not bring more funding to home care and institutional care. If you look at the past, and that's what's going to happen in the future, the provinces will have to make an agreement with the federal government to be able to fund other priorities rather than just having everything be hospital-centric and funding for physicians. We have to look at what the COVID crisis identified. In other words, institutional care. We have to have qualities and standards for quality, and we have to have home care, where funding for home care is not given to institutions as was done with the hospitals, so that the users can have the funding and make the decisions about the public funding. We have to turn to what several countries have already done, to have sort of long-term care insurance. I propose this as being an independence insurance when I was in the government. Unfortunately, I don't have enough time. I didn't have enough time to be able to implement that, but I think it's something that's absolutely essential, and we have to be able to provide quality care. Yes, I understand that you didn't have enough time. As a health minister in Quebec, if Ottawa had said to you, here's money as long as you use it in this particular way, whereas you were the person on the job and your area of the area of competence and the area of jurisdiction is clearly provincial, I imagine you would have said to Ottawa, hey, you can keep your conditions. What we need is money to be able to implement this kind of policy. I imagine that we agree on that. Look, if in recent years Ottawa had announced several billion of dollars of care for home care, had they done this, I mean, my problem is that this money isn't necessarily going to home care. Where the provinces have priorities, we're going to perpetuate a hospital-centric system, which means we're not taking care of the elderly people who have reduced independence, and there are more and more people who are going to be in this situation. Quebec is going to be one of the oldest provinces in 10 years. It's going to be one of the oldest societies in the world, and the healthcare system that we currently have is not at all adapted for that. It's not adapted to that. We are meeting the healthcare needs of people through a hospital approach, which is totally inappropriate. I understand. Thank you. Thank you very much. Thank you very much. Mrs. Blaney, please.
Well, thank you, Madam Chair, and I want to thank all of our witnesses for being here today and for the importance of your testimony. I just want to start off by saying that I agree that this is an issue of ageism. It is absolutely appalling to me that we don't have a meaningful national senior strategy in Canada. I think of all the work that has happened in terms of workforce development, a plan to replace our aging population in the workforce, but there has not been a plan put together about how we're going to support seniors as they age in our country. So I just want to thank everybody for this important testimony. If I could go to you first, Miss Estabrook, you talked about the fact that we're not seeing the very important and skilled workers in this sector be respected, especially with the appropriate pay. One of the things that I saw in my province of British Columbia and across Canada was that a lot of those care workers were working 2 or 3 jobs at 2 or 3 or 4 different long-term care facilities. And as soon as the pandemic happened, some of them lost their employment at other places and were trying to manage their everyday life just doing the one part-time job. I'm just wondering if you could talk about how that has an impact on the services to our seniors.
Thank you. Yes, as many as 30% of PSWs and carries were working more than one job pre-pandemic. About 70% of that group were working for financial reasons, and many of them couldn't make a decent wage. Wages in Canada pre-pandemic ranged from $12 an hour to about 22 or 24. You can't raise a family on $12 an hour. So that condition was there, although we didn't know it. Some of us knew it because we had samples from certain provinces that told us that, but as a country, we really had no idea that this was going on. So the impact is that they were working multiple jobs, and specific to the pandemic, the more places you work and the more you travel, the more you become likely that you will spread the disease. Not through any fault of your own. It's just the more traffic and the more exposure you have, the more it happens. So we put these one worksite policies in place in many jurisdictions, and they have helped, but they come with their own fraught unintended consequences. So if you're a chain and you've got 14 homes and you're used to moving your staff around to cover shortages, and all of a sudden you can't. We saw some really catastrophic shortages, and there've been some lessening of the conditions around that policy to accommodate for that. But the core issue is if you don't pay a workforce and they deliver 90% of the direct care, a living wage, and you don't make it possible for them to have full-time employment with sick benefits and vacation benefits, then you're going to have both a dispersion through different homes. You're also going to have issues with commitment to the organization you work in. I mean, there's just a whole trickle-down effect. So I'm not suggesting that on a permanent basis we might want to put a one worksite policy in place, but the reason people are working more than one job shouldn't be because they can't make a living wage or get sick benefits.
Thank you. I really appreciate that. If I could come to you, Colonel Malcolm, first of all, I would like to thank you and, of course, Major Martin for your service. I just appreciate I'm the lucky MP that represents the 19 wing over in Comox, and they're amazing. And I just know how hard you work and how dedicated you are, not only to our work internationally, but here in Canada, obviously. I'm just curious if you could answer two questions for me. One of them is just what is the process when the military is called? How does that roll out? How do you make an assessment of what's happening and respond to it? And of course, you know, the military did provide a report. I'm just wondering if you could give us a few recommendations of how we could prevent this from happening again in the future. Thank you.
Madam Chair, thanks for the opportunity to answer these questions. I'll cover the first one, and then we'll turn the floor to Major Martin, who will be able to speak to the lessons learned. Just bearing in mind that you know what we saw there was that snapshot in time, and so she will share some of her observations from that moment. So, with respect to how the provinces make requests, I will clarify that as a health services member, and it's outside my lane specifically on how that occurs. The process very generally occurs through the regional joint task forces, and I know that you have had some of the regional joint task force commanders speak in the past, and in very broad terms, the requests are coordinated from a request from the province itself based on the assessments done by the provincial emergency operations centers in discussions with the regional joint task force commanders, and then a request is sent up through the Minister of Public Safety that comes across to the Minister of National Defense. And then based on the requests, the Chief of Defense Staff will have a look at the availability of forces. Speaking specifically to health services, they would come to the Surgeon General to request whether we have forces available to meet those requirements. We would provide the response back to the Chief of Defense Staff, and then the planning staff would look at our overall ability in order to respond to that need. And then turning to your second questions, Madam Chair, I would turn the floor to Major Martin to speak to the lessons observed in her time working in the long-term care facilities in Ontario.
Thank you, Madam Chair, for the question. So a few themes arose out of the report and our observations, certainly echoing what has been said by other witnesses. Staffing was a huge concern. When we arrived, many of the facilities had as little as 20% staffing. So irrelevant of what their nursing ratios were pre-pandemic, that made a huge impact on the outcomes of patients. Secondly was sort of your infection prevention and control, and really having that situational awareness of who was positive, who was negative. There was delays within having the results. Sometimes there was a lag of a week up to 10 days. And so by the time you got your results, you no longer had a good situational awareness of where the outbreak was. And then also sort of that IPAC stream is having centralized and or standardized IPAC protocols. We within the CAF had a central IPAC member who provided us that advice. But IPAC was very different between each of the facilities in terms of donning, doffing, what the standard was for PPE, et cetera. And then finally, training. I think when you are looking at a degradation within the health status of a large population, having individuals who are trained in that acute care is paramount.
Right. Thank you very much for that. Madame Gallant, s'il vous plaît.
Thank you, Madam Chair. And my questions are for the Colonel, Colonel Malcolm. First of all, what vaccine safeguard protocols are in place for soldiers who receive an experimental vaccine?
Madam Chair, to date, there's been no experimental vaccines, to my knowledge, that have been used on Canadian Armed Forces personnel, nor is there any intent to use any experimental vaccines on our Canadian Armed Forces personnel. Thank you.
Who is responsible for providing financial compensation for soldiers who suffer adverse reactions to a vaccine, or this vaccine for that meaning?
Madam Chair, I'm unaware of any claims by serving or former serving CAF members for against the use of an experimental vaccine. As I mentioned, to my knowledge, there has never been an experimental vaccine used on our force, and therefore couldn't comment as to how what the compensatory mechanism would be for that. Thank you.
Okay, we did see with an anti-malarial drug that our soldiers were amongst the first in Canada to be dispensed that, and it has been quite an uphill battle ensuring that this required inoculation has been adequately compensated for in the instances where they had the bad reactions. Will the government confirm that no military insurance policy will be voided for soldiers who take this COVID vaccine administered by the military?
Madam Chair, it would be outside my my authorities to make a determination on that. Regrettably, not a decision that would rest within health services.
Okay, through you again, Madam Chair. On whose shoulders would that responsibility lie?
Madam Chair, regrettably, within my position, my current position as Deputy Surgeon General, I wouldn't have the answer to that question. I'm not responsible for the insurance plans of our members. I honestly couldn't suggest right now who within the department would be in a position to answer that question.
Thank you. Once a vaccine is available, it doesn't make a whole lot of sense to vaccinate soldiers and not their families. When can military families expect to receive a safe vaccine?
Madam Chair, with respect to the prioritization of the impending COVID-19 vaccines, those prioritizations will first be made at the cabinet level based on expert advice, including from the National Advisory Committee on Immunizations. And it will be based on those priorities, at which time that it will be determined when our Canadian Armed Forces members will be vaccinated. And also prioritized among those, along with all other Canadians, will be the families of our military members. Thank you.
For the next roto to Latvia, what are the current COVID precautions being made for soldiers who are headed there?
Madam Chair, thank you for the question. And for our troops deploying to Latvia and for all of our troops deploying, measures are being taken to ensure that our members are not bringing disease into the country nor impacting those being deployed. And so those folks are being quarantined in advance of their departures. And we've also been conducting operational testing on our members being deployed overseas to ensure that they don't have, as we've termed it, asymptomatic, meaning being infected with COVID-19, but not demonstrating any symptoms. And then, of course, the Canadian Armed Forces has led the way in implementing very robust public health measures, including physical distancing, the use of masks, diligent use of hand washing, and also strong recommendations for folks to have the influenza vaccine prior to their deployment, just to eliminate one other type of infection that could impact operations. Thank you.
All right, thank you very much. Monsieur Robillard, s'il vous plaît.
Mr. Robillard, please. Yes, thank you, Chair. And thank you, and hello to the witnesses. My first question is for Carol Estabrooks. First of all, I'd like to congratulate you for your recent appointment to the Royal Society. Thanks to your expertise on the subject, I would like to hear what you think about the role of women and visible minorities in long-term care institutions. More specifically, in positions such as a personal support worker or nurse.
I'm not sure
Point of order. I'm just wondering. I'm hearing both languages at the same time.
Okay, thank you. Let's look into that.
So was I.
Try it again.
I start all over?
Should I start all over?
Do I start all over?
Wasn't available, and Madame Estabrooks, I think the question was directed to you. Is that correct?
Yes.
Were you able to hear the question?
No, I only heard about half of it.
Okay, then yes, please start all over again. Thank you.
Okay. Alors, bonjour.
So, hello to the witnesses. My first question is for Madame Carol Estabrooks. Is that okay? Can you hear? You're hearing now?
Si je peux me permettre, Madame la Présidente,
Madam Chair, I think you have the choice between mute, original, or audio in the various options for interpretation. At the bottom of the screen, there's French, English, and there's mute, original, audio. I have the correct one on. Do I have to do that myself here?
La proposition, Monsieur Duceppe.
Mr. Is that what I do? Yes, please try that. If you look at the center of your screen, you see interpretation. Click on the French. Under French, you see mute, original. That's to mute or unmute. Okay, is this okay now? For our point of view, it's okay. Can you say something in French? So, hello to the witness. My first question is for Mrs. Carol Estabrooks. And now is everything okay? Is it working okay now? So I should continue? Okay. First of all, I'd like to congratulate you, Madam Estabrooks, for your recent appointment to the Royal Society of Canada. Thanks to your expertise on the subject, I would like to hear what you have to say about the role of women and visible minorities in long-term care institutions, more specifically in positions such as PSW or nurses.
Thank you very much for the question. Over half of the PSW workforce are immigrants. Over half of them, the people who are immigrants, don't speak English as a first language, and sometimes don't speak English well enough to understand readily in a conversational way. So it's a highly racialized workforce. We pay almost no attention to that. We don't collect that data. I have that data because we've been working over 15 years with a longitudinal group in the West, and we ask them what language they speak and where they came from, and so we have that data. When I talk to colleagues in Ontario and Quebec, it's even higher. It's not the same in some regions of BC, and in the Maritimes, it's a little bit different. It depends on the ecosystem that you're in. That is part of the issue of why they are so poorly compensated. They're women, they're poorly educated. They're not given any continuing education. They're not regulated, which means there aren't even criminal background checks, and we don't count them accurately in the country. So what we have done is create this workforce that's largely unregulated, and we've deprofessionalized it. In Germany, they legislate that 50% of the frontline workforce have to be regulated nursing staff, RNs. In Belgium, it's even higher, almost 65%, and that's similar in other jurisdictions. Here, the regulated workforce is less than 15%, and that has been a financial decision, coupled with the belief that you don't need complex, competent, skilled care for these individuals. We can provide that care with a high proportion of unregulated staff, but we have to give them proper education, and we have to give them continuing education, and we have to support them, and we have to address what kind of issues does it create if we have a highly racialized workforce in terms of the discriminations they feel. We know that COVID had a disproportionate impact on racialized groups, and we know that in some jurisdictions that was manifest in what happened in the workforce in the nursing homes if they had a particularly high proportion of groups from other ethnic groups. Poverty plays a role. The fact that they're women plays a role. So all these things come together and they stack until you get a workforce that's quite vulnerable. And then on top of that, they're pretty much voiceless. They're not unlike the residents who don't have a voice. We don't give them much voice. They're at the bottom of a hierarchy, and they're not included often in a lot of decision making. They have but they care. This is the thing that astonishes me. Through all of that, the average care rate or PSW in this country builds relationships with residents and cares and wants to do good work. We aren't even acknowledging that's the first step. And then we have to look, what does it mean when so if a workforce is predominantly female and you've got COVID and they close the schools and there's no childcare, that's a problem. If you're a woman and you've got children and the schools are closed and you're caring for aging parents, that's a challenge. So we've got issues, and we don't value caregiving. And we don't value it for children, and we don't value it for the elderly. So there's a very big convergence of these compounding issues of disparity and inequality in this workforce.
All right. Thank you very much. Monsieur Brunel-Duceppe, s'il vous plaît.
D'accord.
Mr. Brunel-Duceppe, please. Excuse me, the time is for Mr. Brunel-Duceppe now. Oh, sorry, my apologies. Sorry, Mr. Robillard. I'll make it up to you. Thank you. I'd like to thank the interpreters who are doing an exceptional job. I do want to say that they are exceptional. Thank you very much. So it's not every day that we get to have a former health minister at the Defense Committee, as you've mentioned, Mr. Hébert. Very happy to have you with us. Just to be sure, do you agree with Quebec and the other provinces' demands of Ottawa to increase from 22 to 35% the payments? Can you hear me? I've changed my headset. Yes, we hear you very well. I think that both at the federal level and at the provincial level, we need to have an increase in funding for healthcare. But as I was saying before, if the money is continued to be invested to improve physicians and hospital-centric care, that's not the right focus. Yes, I understand that, Mr. Hébert. I don't have a lot of time. I understood that point. I did want to ask you, as a former Minister of Health of Quebec, do you agree with Quebec and the province's ask from Ottawa? What I'm hearing in this speech from the throne, when I hear that you really want to emphasize home care and institutional care, that is music to my ears. I think there's some significant negotiation that has to be undertaken with the provinces so that those funds truly be spent on home care and institutional care in Canada in each province. So as a former health minister, you disagree with this request? That's what I understood. So I have a last question for you, because you were saying that in 2013, the federal government was not giving any services to the population when you were Minister of Health. You were saying this, and that there was redundancy of staff and that was expensive. Do you still agree with that statement? There are, in fact, areas where there is redundancy. For example, at that time, for mental health and for Indigenous populations, I think their efforts can be made so as to be able to come to an agreement about eliminating the redundancies. There is so little funding for health. We really have to be careful to ensure that there isn't a redundancy in the way it's used. Thank you very much, and now we understand your positions. My question is now for... Hello, Major Martin. My question is for you. There are several major important courses, such as career advancement courses, which have been cancelled or which had limited candidates in them, which means fewer soldiers being trained, fewer officers, etc. All of those people who could have trained other applicants. I think COVID has really hurt everybody, especially in this area. Could you tell me what the impact of these lags are on the preparedness of our forces?
Thank you, Madam Chair, for the question. The preparedness and or questions about training are not within my field of expertise, but I would turn the floor over to Colonel Malcolm, who would be better positioned to answer. Thank you.
Okay, parfait. Merci.
Very well, thank you.
Madam Chair, thank you for the opportunity. I'll have to speak in my current role as Deputy Surgeon General with respect to that. Back in March in the first wave, in an effort to respect the public health measures being put in place by each of the provinces, the Canadian Armed Forces took a very disciplined role to cease our operations, to stop moving training candidates from across the country, so as to avoid becoming a vector. And certainly, it did slow down our training operations at that time. We continue now respecting with the new information we have with the virus and adhering to those public health measures, have started to restart the training machine as of this fall. And while we do have some catch up to do, we do have a plan in place to move that along. And in terms of our current preparedness for a wave 2, we stand ready to assist as requested by the government of Canada. Thank you.
All right. Thank you very much. Mr. Garrison, please.
C'est déjà fini, merci.
Already finished. Thank you.
Thank you very much, Madam Chair, and thank you to the witnesses for being with us today. I apologize, I had responsibilities in the House of Commons that prevented me from joining earlier, but I know that MP Rachel Blaney did a good job, I'm sure. I guess I want to start with a question to Colonel Malcolm and or Major Martin, and I apologize if this overlaps in any way. But I did hear part of your responses earlier. And my question is about, given the lessons we've learned, do you feel that there's a danger, given the current spikes in COVID-19 we're seeing, especially in Ontario and Quebec, that the Canadian Forces might have to be called upon again to provide assistance in long-term care homes?
Madam Chair, I will take that, and I think we're seeing right now that we do have members deployed to support the long-term care facility in northern Manitoba. So it certainly remains top of mind for the Canadian Armed Forces, and we have our teams prepared and ready to go, much as they were in wave 1, should additional asks of that nature come from the provinces. Thank you.
And are there differences, given the lessons you've learned, in how you'll approach intervening, say, in Manitoba now, or if you had to go back into homes in Ontario and Quebec?
Perhaps I'll provide Major Martin, who has that coalface experience, to speak to what we've learned from our experiences there. Major Martin.
Thank you, sir, and Madam Chair. From our first experience, one of the big pieces that we learned was team composition and really looking at what were those critical clinical capabilities. And certainly nursing was at the forefront of it. So as part of our lessons learned, we had submitted observations to Ottawa to bolster that team. And again, that's going to be predicated on staff availability, clinical availability, but certainly more personnel when you're looking at severe staffing shortages. Thank you.
And given we've seen COVID now appearing in rural, remote, and Indigenous communities in large numbers, which have often very limited health facilities, is there a contingency plan in place for Canadian military to provide assistance to those rural, remote, and Indigenous communities in coping with this spike in COVID.
Madam Chair, thank you for the opportunity to respond. So dating back to wave one and our work with the whole of government response plan for COVID-19, part of our planning was related to the potential to respond to the requirements to support rural, remote, northern communities. Thank you.
Right. Thank you. Thank you very much. Now to Mr. Dowdle, please.
You're muted, Terry.
There we go. Thank you, Madam Chair. And thank you, James Bazan. I just want to take an opportunity to thank all the witnesses that are here with us today, and certainly to the military, all the men and women for what they've done during this crisis. I just want to make one quick point. I know we've been short of time. We're worried it's a Friday. Just the one concern is that I think the study and what I'm on this committee for was originally the pandemic and the Canadian Armed Forces. I know we're getting into other discussions that I know because we're short of time. It was fantastic if we could sort of maybe narrow it down to how it's really truly affecting our forces. So anyway, with that, I'll just begin by saying that we had the opportunity on Monday. My question is going to be to Mr. Shmuka. And on Monday, we had his distinguished colleague here, Dr. Lopresh, and he testified before this committee, actually, that in his opinion, 25% of our active armed forces dedicated domestic operations, like we saw here in Operation Laser, that the Canadian Armed Forces response to the COVID pandemic is ineffective use of military resources and will begin to harm our readiness, definitely for international responsibilities. And I'm just wondering if perhaps you agree with this assessment, that Canada should perhaps look at, standing up and funding a dedicated section of the Canadian Armed Forces for exclusive domestic operations, or if you don't agree with that statement. So I would couch my answer by saying I think that's not precisely a question for me. I think that's a question for, I guess, the body politic, right? And determining what are the roles that the government wants to do for Canadian. I look at different militaries internationally. Well, let's just say like Coast Guard, right? Or sort of protection of sovereignty, right? Canada uses its navy in a fashion that is probably more extensive than countries that have a more sort of robust Coast Guard capabilities, like let's say Japan or something like that, right? So relating that back to sort of pandemics and sort of aid to the civilian power missions, like with in this case, I think it is a reasonable ask, so long as there's planning and capability, or planning and resources allocated that are commensurate to the task. I think too often governments will saddle the Canadian military with a task, and as the fine representatives of the Canadian military here will show, they will do it at to their utmost capability and ability, but the resources aren't applied and given to that mission, right? And that's just not with with the aid to civilian power mission. That's with a lot of different areas. So I would say my view is that I think that could be a legitimate use of the Canadian military. It just needs to be resourced properly and be clear as one of the tasks that they must fulfill at the time.
Thank you for that. And also, COVID-19 and the rise of social isolation and physical distancing has affected how we plan and execute our military operations here at home and definitely abroad. Do you see more future use of cyber warfare and artificial intelligence? And what are some of the issues there in terms of our international norms?
I would argue that I think that those areas of capabilities are increasing anyways. They are becoming some of the leading edge of military capability and power that we're seeing internationally. I can point to just a couple of days ago, the UK has announced I believe, a 13 billion pound increase in their defense budget over a couple of years, and a significant portion is going to go to cyber warfare capabilities, right? And we see the United States and whatnot. So I don't necessarily believe that might be in regards, or it might be as a result of COVID or the pandemic itself, but certainly those are major areas of capabilities I think that are increasing in relevance in an international sphere.
Thank you very much. I don't know if I have a lot of time yet, so my quick question maybe to Colonel Malcolm. How many Canadian Armed Force members are currently deployed on Operation Laser?
Unfortunately, I don't have the exact number right now. I'd have to take that one on notice in order to get back to you.
And then just a quick follow-up. I know you don't have the number. That would be interesting for sure. But also, do you know if those members will be deployed on the operation to coordinate vaccine distribution as well?
Madam Chair, at this time, the role of the Canadian Armed Forces in the rollout of the vaccine is still being explored. Right now, we have members of logistics experts and planners working with the Public Health Agency to assist in the planning, but it's yet to be determined what other roles that Canadian Armed Forces may play in the rollout of the COVID-19 vaccine. Thank you.
All right, thank you very much. Mr. Bagnall, please.
Thank you very much. And thank you to all the witnesses. I don't have a lot of questions because your testimony and your written input is so comprehensive. And thank you for the passion which you are protecting people that cannot really protect themselves. Some of you in the military and others have put themselves at risk. And so I really appreciate the efforts of all the witnesses and those who have done that. And also like to congratulate Major General Fortin, who's going to head up vaccine logistics and operations for the military that the Prime Minister announced today. Just to go on, make a reminder that in all the recent previous years, each year there's been an increase of transfer to the provinces and territories and for healthcare, and particularly thank Professor Herbert for mentioning that we made a record contribution, first time ever, on home care in recently, which I think everyone in the here would agree is very important, especially considering recent events. My questions are for Major Martin, and as you know, a high priority of everyone on the committee is increasing the importance of women in the military. And so I just want to, my two questions for Major Martin are along that line. First of all, I'm delighted you've been given such a senior and important role. That's fantastic. And for all reports, you've done a wonderful job. Have you noticed any special needs? I know Mr. Robillard asked this question as well, but for either the women that are in the long care homes, either as patients or as workers, special needs they have, recommendations specific to women, or if there's any discrimination similar to the ageism that was discussed earlier, but specific to women. Any comments on that from your experience in your management role in this situation, Major Martin?
Thank you for the question. I would say that when we're looking at staffing within long-term care, as described within some of the other testimony, certainly being able to provide childcare, being able to provide care to other family members did impact those PSWs and those nurses when things started to shut down. So certainly there was a level of staffing degradation that was related to the role of women. In terms of discrimination, not that I witnessed or not that was reported to me. I think majority of the managers that we worked in all the 7 homes were females, and so they were certainly a very prominent leadership role that women played within that sector.
Thank you. And my other question is that yesterday I was on a conference call with an organization, not military at all, but a similar type of organization, and they asked what they could do to increase the recruitment of women. And you're obviously very successful. You were recruited. You've risen to the top. But any suggestions you have about how we could increase women entering the military, how we could improve our recruitment efforts related to the special needs of women, and anything from your personal experience that might help us guide us make improvements.
I can speak from personal experience. My husband and I are both military and have had almost 20-year career together. Certainly having communication about the support to families and the support to the career for women is very important, but also better communication on what it is the military does. I think from an outside perspective, most civilians look at the military as being that very infantile, very hard army type of mentality. And I think really just that communication that there are wonderful opportunities within this organization.
Thank you, Madam Chair. That's all I have.
All right. Thank you very much. Mr. Bazan, please.
Thank you, Madam Chair, and I want to thank our witnesses for appearing. I want to thank our military members who are with us, Colonel and Malcolm and Major Martin. Major Martin, particularly thank you for your testimony at the Ontario Long-Term Care Commission. I think it was brutally honest and really gave everyone a clear picture of the unfortunate events that unfolded and that you were and your team were sent in to clean up. Wanted to just ask a couple quick questions to Colonel Malcolm to start off with. If we were in an operation like Afghanistan and had so many of our medical personnel deployed, managing Role 3 hospitals and forward operating bases, would we have been able to handle the domestic response that was required during the first wave of COVID-19?
Madam Chair, thank you for the question. And obviously, I can respond only from the health system perspective, and certainly what we.
But that's what I mean exactly. Is a number of people we had deployed. Role 3, we had medical personnel at our forward operating bases throughout Afghanistan, and if we had all those people deployed, how would we manage a pandemic like we're experiencing right now?
Madam Chair, thanks for the opportunity to answer this question. And really, in order to tackle this very complex problem in the spring, we took a very different approach to it, and we looked at it through a very needs-based health workforce planning lens. And so we looked at managing individual professions in this regard. And so we had to make some very deliberate decisions. And certainly, in the face of a large-scale deployed operation like Afghanistan, more challenging decisions would have had been made to manage the needs of a larger deployed force and balancing those with the domestic requirements. Thank you.
Now, is medical health services going to be required to participate in the rollout of the COVID-19 vaccine, especially now that General 410 has been appointed as the leader on the distribution of COVID-19 vaccines?
Madam Chair, thanks for the opportunity to respond to this question. As of right now, the additional roles of the Canadian Armed Forces and specifically Canadian Force Health Services remain yet to be determined, though I will note that in the Omnibus RFA that was developed as part of Operation Laser, one of the planning contingencies included in it is a role for the Canadian Armed Forces in mass vaccination. So that's factored into the planning, but it remains yet to be determined whether or not we will be required in that regard. Thank you.
So in preparation and as part of your training and readiness, would the Canadian Armed Forces and through your health services group be right now training members of the Canadian Armed Forces to actually administrate vaccines across the country?
Madam Chair, as part of the training for a number of our clinicians, the administration of vaccine is standard part of their training, and the vast majority of those folks, be they med techs, nurses, or physicians, are currently administering influenza vaccinations to our troops across the country. Thank you.
Now, I understand, Madam Chair, that Canadian Armed Forces, of course, has been discussing their participation in the distribution of COVID-19 vaccines for some time as part of Operation Laser. Colonel Malcolm, have you any idea on how many members of the Medical Health Services Group are going to be required to help in this section of Operation Laser in the distribution of COVID-19 vaccines?
Madam Chair, as the military continues to gain a greater understanding of the needs that Public Health Agency and perhaps the provinces and territories may have with respect to the rollout, it remains yet undetermined the role that Canadian Forces Health Services may play, noting that we have provided a pharmacist and a healthcare planner as part of that initial planning team. Thank you.
So in this planning process, when would the Canadian Armed Forces, under the leadership of General Fortin, have a solid plan in place that can be explained to Canadians from coast to coast to coast, so they understand how the vaccines are going to be distributed, what role the Canadian Armed Forces are going to be playing, how do we get to vulnerable populations, and how do we inoculate those that are living in rural, remote, and northern communities.
Madam Chair, that would be a question better placed to Major General Fortin and the Public Health Agency of Canada. I'm not privy to the details and where things stand on that plan at this time. Thank you.
Okay.
All right, thank you very much. Over to Mr. Baker, please.
Thank you, Madam Chair. And I'd like to first ask my first question to Professor Estabrooks. Professor, it's good to see you again. I have about 5 minutes, so I'm going to try to split my time between yourself and Monsieur Hébert if possible. So if we can keep it within 2 minutes, I'd be grateful, just so I have a chance to ask him a question as well. Professor, do you believe that it is important, in light of what the Canadian Armed Forces discovered and revealed as far as some of the practices, some of the conditions in our long-term care homes, do you believe that it's important that national standards for long-term care be established, and if so, why?
Yes, I do, for some of the reasons articulated earlier, that there's a patchwork of what you can expect across the country. It would raise educational standards. It would raise probably care hours in our understanding of the kind of mix that's provided. It would raise the minimum reassure, and it would help the public understand that there's a national interest and a common understanding of what you can expect when you get old and need long-term care. Not everybody's going to need long-term care when they get old. Dementia is the main driver of admission to long-term care, but those people whose needs overwhelm the family and the community in home care and do need long-term care, for them it's the right place to be if it's done properly. And I think right now Canadians are afraid, I know they are, to go into a nursing home, and the pandemic has exacerbated it. So there's no sense, I don't believe, in the country that this is a national effort in the same way, even though it's still a bit patchwork, that healthcare is. Long-term care is not healthcare. It's a combination of social and healthcare. And there's really no sense of cohesiveness that I can see in terms of what you get to expect when you get old and need that kind of care.
Thank you very much. I'll switch to Monsieur Hébert now. Monsieur Hébert,
Mr. Hébert, it's a pleasure to meet you virtually, and I'd like to thank you very much for being here with us today. My question is the same as I've just asked of Ms. Estabrooks in terms of national standards for long-term care homes. In the speech from the throne, the government announced that it was going to be working with the provinces to set national standards. Do you agree that this is something important to be able to improve conditions in long-term care homes? Thank you very much for that question. Yes, I agree, because in every other area of activity in medicine, we have either Canadian standards or international standards. So if we're talking about diabetes or Alzheimer's, obesity, cardiovascular disease, we have international or national standards, and they have to be based on the best possible scientific evidence. And as Canadian provinces share similar health systems, it is logical to put the provinces together to be able to benefit from the expertise and the experience of each of them. We also have to consider that in Quebec, our healthcare services are certified by Certification Canada, which has national standards, which apply those standards to Quebec and has been applying them for several decades now. So we should be able to count on standards not only that are Canadian, but also international, so that Quebec and Canada have the best possible standards in the world to be able to take care of institutionalized elder people. Thank you very much.
Major Martin, if I may, I only have about a minute left. So, but if I may, I'm just wondering if you could share with us some of the most horrific conditions or things that you saw, whether it be conditions or practices that you saw in long-term care and some of the things that you think might be done about them. I don't know if Major Martin can hear me.
My apologies that my sound went out. Could you repeat your question, please?
Yeah, sure. We have about 45 seconds. So just briefly, what were some of the most horrific or difficult conditions that you observed, or you or your personnel observed in your service in long-term care, and what could be done about them?
Certainly, the report answers much of that, but I think for the clinicians, it was actually seeing patients dying alone or patients not having their family with them was very challenging for all of the clinicians involved.
All right, thank you very much. Okay. We'll go on to Monsieur Brunel-Duceppe, s'il vous plaît.
Merci, Madame la Présidente.
Thank you, Madam Chair. I just heard what Mr. Hébert was saying about national standards. I have a question for Mr. Hébert. Does the Quebec Health Department use strategies for mental health and seniors care right now? Yes. The Quebec government has strategies for mental health and care of the elderly. What I'm very upset about is that these strategies have not been given priority. And so we end up with a hecatomb again, which is much greater in Quebec than anywhere else in the other provinces and countries that are in the industrialized world. So that's because of the negligence of this activity sector. So Quebec has elder care strategies. And you were saying it would be music to your ears if the federal government, who, as you know, doesn't administer any hospital, or maybe only one or two, that they're better placed to go over the people who are in the field. Is that what you're saying? That's absolutely not what I said, Mr. Brunel-Duceppe. But if you're talking about national standards, that's what it means. No, that's not what it means. It means that we can pool together scientists in Canada to be able to determine what the best practices are, as is done in several other areas. Science doesn't stop at the border of Quebec and Ontario. Science is pan-Canadian and science is international. So I think that one must not be chauvinistic. No, it's not about being chauvinistic. You would have accepted this as Minister of Health of Quebec. You would have accepted national standards from Ottawa. I have always accepted the fact that Quebec should comply with the best norms of practice for service quality or for a mode of treatment or diagnosis. I think Quebec must be at the cutting edge of standards that are national, Canadian, and international. So you find that Mr. Legault is out in left field when he says he doesn't agree with national standards, but you as a PQ minister, you would be in agreement. You are putting words into my mouth, Mr. Brunel-Duceppe.
To Mr. Garrison, please.
Thank you very much, Madam Chair. And one of the things I'm very pleased today is to see the discussion of long-term measures for long-term care that might help prevent the future need for the Canadian Forces to use their resources to provide this assistance. And I was particularly pleased to see Mr. Hébert talking about the need to move from a hospital focus to a home care focus, and from Professor Estabrook and Ms. Boysenkamp to talk about the need to recognize and appreciate care as an important service in terms of accreditation of staff, training of staff, living wages, and all those kinds of things. So I know we're nearing the end of our time. My last question is about short-term measures. And I think I'll ask Ms. Boysenkamp first. Do you believe that the measures were taken before the Canadian Forces departed from long-term care homes were adequate to guarantee the health and safety of patients in long-term care homes in Ontario?
Thank you for the question. And no, I don't think the measures were adequate. In my view, the biggest issues were testing, which I spoke about. Long-term care should be given priority for testing. As soon as there is a confirmed case, everyone should be tested so that that population can be appropriately cohorted, negative with negative, positive with positive, If that can't be done, you take the positive people out of the location. And that was a problem in the spring, and it's still a problem now. So it's testing, it's the cohorting, those basic things that allow the teams on site to manage the outbreak are not systematically in place, and they're still not in place in Ontario.
Thank you very much. I'm sorry that's the answer we have to hear, but I think it's important for us to hear that. Professor Estabrook, I would ask you the same question about short-term measures. Are there important short-term measures that you see could put in place now to help mitigate the negative circumstances that we're certain to face in the coming months in long-term care homes?
Thank you. Obviously, we've got to address the testing issue. We've got to address the infection and adequacy of PPE. That's just fundamental, and it's not addressed everywhere. We have to continue to hammer away at the staffing issues because we have outbreaks right across this country right now, and the death tolls and the toll on suffering is not restricted to Ontario and Quebec right now. It's right across from border to border. The one thing I think we have failed quite significantly at is we haven't understood that public health measures affect long-term care. Long-term care doesn't sit in a bubble hidden away in some mountain range. If people aren't complying with public health measures, it will ultimately affect the positivity rate in long-term care, and it will ultimately result in deaths and untold suffering. So we've got to try and understand and help the public understand that we must enforce public health measures because the people in the long-term care setting have no ability to protect themselves beyond what we do for them. So that would be I think a key issue that we've got to address. We've
All
also
right,
got
thank
to
you very
address
much.
loneliness.
Mr.
We talk about
Bazan,
people
please.
dying alone as if it's just a sad thing that happens. It's a catastrophic event, and loneliness and isolation kill people before they ever get
All right.
to the very end of life. So we've got to manage visiting in as safe a way as we can and not shut it down entirely like we did.
Thank you very much. Mr. Bazan, please.
Thank you.
Thank you, Madam Chair. And my questions just around are going to be directed towards Mr. Shimuka. Now, you have done quite a bit of analysis of military spending in the past, and we know that there's been a lot of spending during this pandemic to stimulate, to fill in the gaps in incomes for individuals and businesses. Now, once we get this under control, have you put any thought into how future budgets by the government could impact on defense spending?
Yes, thank you for the question. Absolutely. So it's interesting to just take a little international view right now. I'd like to point out that many countries, point out France and the UK, have actually boosted defense spending specifically in the acquisition sector, accelerated purchases of equipment as partly as a way to stimulate the economy. I think in the last year, you've actually watched, or during the sort of time of pandemic, you've actually watched 3 major tactical fighter air programs that are somewhere in the region of 20 to 30 billion dollars worth of spending be announced and sort of see the seed money in those programs in order to it's sort of as a stimulus measure, partly because the aerospace industry in particular has been extremely hard hit, as we all know, right? And not just in regards to travel, but the actual manufacturing and MRO side. So, with that being the case, Canada hasn't really done that. Canada doesn't have a national sort of defense aerospace or defense procurement strategy in the sense that it is well developed and providing money for investment of capabilities and like. So I think what's going to happen.
Should we have that strategy?
Absolutely, I think that's part of it. We have the what are called the key investment capabilities, or sorry, excuse me, the KICs. And what we do is we take the ITBs, the industrial technical benefits funding, and use that to support Canadian industry. It's not really an effective strategy. A lot of countries have moved away from such strategies. And I think the government is going to look at the KICs and try to use those in order to try to fund domestic priorities. in a kind of roundabout way. And that's just going to cut into the budget of the Canadian Armed Forces for procurement and also increase time and delays for equipment. So, I'd probably caution the government towards looking at that way as kind of a way to, as a stimulus measure for the Canadian, for sort of the economy. And I'd quite worried that is actually what they're looking to do.
So how would you balance off then the interests of, economics drivers along with capabilities required for the armed forces and trying to procure that in the best interest of the taxpayer?
I think that there's a balance, and I'd probably point to some of the stuff that the United Kingdom and Australia have done in the last decade or so, where they've kind of moved away from very rigid formulas where you say, you have to have 100% domestic offsets for foreign purchased equipment, and sort of move to a more flexible arrangements that actually look at what's the value of what they're getting and sort of the development of domestic industries. But they also provide significantly large direct investments from the government, rather than just trying doing it completely through the ITP format. I think that's a real danger that we have in Canada, and you start to see real problems associated, especially with now that you can actually alter the selection of military capabilities based on the value proposition or the amount of ITVs or where they're located or the value according to the assessment criteria based on that. So that's
so let's just look at the standpoint of one thing that we learned through COVID-19, through this pandemic, is that we didn't have sovereignty over the production of PPEs. We don't have sovereignty over the production of COVID-19 vaccines. We're dependent upon other nations to provide that. Is there critical infrastructure within the Canadian Armed Forces that we should have sovereignty control on? Control over some of these supply chains are critical and paramount to the protection, safety, and defense of Canada.
A quick answer, please.
I'd say stuff like cyber warfare, stuff that really requires really rapid and quick development, and having the IP control over that, especially within Canada. Those are the areas that definitely Canada should look at towards maintaining a domestic industrial base.
Right. Thank you very much for that. Okay, Mr. Hardy.
Well, thank you, Madam Chair. You run a very, very tight meeting. That's very good. Of course, what would we expect? To Major Martin and Colonel Malcolm, the Canadian Armed Forces must have gained some experience 102, 103 years ago with the Spanish flu. Was there a playbook? Were there learnings from that have you've been able to carry forward into the situation that you're facing now?
Madam Chair, thanks for the opportunity to respond to that question. I would suggest that documentation and maintenance of that documentation over that century, while somewhat challenging, certainly we were able to look back to our more recent lessons that we had through specifically the H1N1 experience and look at roles there. So there were some lessons learned, but I would suggest that again, we're looking at more of a known entity in an influenza with H1N1 and much more uncertainty with this pandemic being the first ever for a coronavirus. Thank you.
Thank you. Early on in our experience with the pandemic, we watched in shock and horror as to what was going on in Europe, particularly in Italy. And that was certainly where I saw the first involvement of the military in helping civil authorities deal with the situation. Has there been discussions, exchanges of intelligence, ongoing liaison with military in Europe as to how they've been dealing with this, and are there learnings for us?
Madam Chair, thanks for the question. Both through our NATO allies and through other partners that extend across the globe, we've been receiving valuable lessons, whether it's from Japan, Korea, everyone in the military sphere is quite willing to share lessons, and we've been keeping abreast of those throughout this time, which, given the fact that the first wave came a couple of months after it struck the other side of the world, we were able to be somewhat better prepared given the limited knowledge that was available at that time. Thank you.
Well, it seems that you will be called on the the whole issue of getting the vaccines out. How good are you guys at logistics? This is your commercial.
So unfortunately, Madam Chair, you're asking a doctor about how good we are with logistics. So not my area of expertise, but I can tell you when it comes to medical logistics specifically, we relied very heavily on our medical logisticians to get PPE around the world when we supported Operation Globe, and also to get it to into the long-term care facilities, and they did marvelously. And no member went into those long-term care facilities without having the top quality PPE that they required to protect them and the vulnerable populations that they were serving.
If I have time for another quick question to Ms. Esther Brooks and Busenkom, Van Busenkom, isolation. It's been mentioned. What do we do about it? What are your suggestions?
Thank you for the question. We can eliminate risk, so I think we have to understand that we accept some risk when we allow visitors and family in, but we can mitigate that risk. We can limit the number of people in. We can ask that families comply, and if families don't comply with the infection control practices, they shouldn't be able to visit, but we must let them in because an individual who's older with dementia deteriorates not just physically from being alone and in a bed, but very rapidly cognitively when they have no contact, in particular with familiar people. And remember, people are walking into the room with masks and gowns and hats, and they don't have good sensory comprehension as their dementia progresses, and they can't hear well and they can't see well. And so it's frightening and confusing. So we can mitigate the risk. We must accept there'll be some, but I think we can do this quite safely if we're thoughtful about it. And we have to. We can't let people die alone. Thank you.
And there's a great precedent in Ontario with the Essential Caregiver Program, which was introduced thanks to the lobbying of many people. Each resident now has the right to 2 essential caregivers. I am one for my parents. That makes all the difference. We're tested regularly. We're trained in PPE and infection control protocols, and it makes a world of difference. Going into their home, I see the decline of people who don't have access to family members. It can be done safely, and Ontario is actually a leader in that regard. That should be extended across the country, in my opinion.
All right. Thank you very much. And so that brings us to the end of our time. I would like to say merci beaucoup à tout le monde. Thank you so much for your brevity and for treating the time of the fellow witnesses and committee members with such respect. And I thank you for being with us today. We know your time is precious. Merci beaucoup à tout le monde. And with that,
thank you very much to everybody.